Okay. Class, I'm going to go ahead and finish recording the review I was going over the other day. I believe we stopped around, let me go back a little bit. Some of this may be a repeat, but let me go ahead and do that so that I don't miss anything that I wanted to cover. So in assessing mom postpartum, of course, remember they are more prone to blood clotting. You need to understand why. You also need to understand your nursing interventions. Of course, early ambulation is number one, okay, is your priority. We've talked about the Homan sign as part of the bubble he assessment, even though there's some evidence out there now shows that one, it's not always indicative of a blood clot in the lower extremities, and then also there's some evidence that shows it may dislodge the clot. But we can still assess for asymmetrical swelling, redness, pain in the calf, pain when they walk. And we need to you need to review the risk factors for developing blood clots during pregnancy and also postpartum, and then the signs and symptoms of a pulmonary embolus, which is a clot breaking off and traveling to the lung, to the pulmonary artery to be specific. Okay. Signs and symptoms of a pulmonary embolus would be, of course, tachypnea, dyspnea, chest pain, shortness of breath, maybe even coughing up blood. These patients need to be monitored every 4 hours. Their vital signs. Of course, what would warrant further assessment would be maybe a temperature of 100.4 or greater after 24 hours. Remember that mom's pulse, if she is starting to get sick and develop an infection, her pulse is going to be more tachycardic, but normal, healthy postpartum women, their pulse is typically slower and maybe even bradycardic. Okay? Bladder, we want to make sure to check their bladder that they're urinating, that they're voiding at least 30 mils per hour or more often. Typically, the first 3 times they get up after delivery, we're going to measure their urine to make sure they're putting out adequate amount of urine. We want to ask about burning. We want to teach her after every urination and or bowel movement. We want her to do peri-care. We want to teach her how to apply the pad correctly from front to back and also to remove it from front to back. Constipation can be a big issue postpartum, so especially if they're taking pain medication. Again, ambulation, fluids, fiber, fruits and vegetables, okay, is huge. Important that we prevent, and even stool softeners are typically prescribed. And know that moms are going to be stiff and sore, from pushing or from the surgery if they had a C-section. And again, ambulation and moving around will also help those aches and pains to wear down or wear off. You need to go back and review ROGAM. We've talked about this several times already this semester. Just go back and review who gets ROGAM and why. Also, other immunizations such as rubella. If they are not immune, they need to receive the vaccine in the immediate postpartum period. We do need to educate mom that she does not need to get pregnant for at least 1 month. That's very important. Also, know that after delivery, mom's white blood count is typically elevated due to all the inflammation from the labor and the delivery process. So that's not always indicative of an infection. So we need to be paying attention to other signs and symptoms of infection. Know your bubble assessment that we do during the postpartum period. Also review in your chapter about how proper hand placement during fundal check. One hand over the symphysis pubis with a light or slight downward pressure, with one hand lightly massaging the abdomen until you palpate the top of the fundus. And again, that massage is, you get stronger with it as you progress with it. Don't start out just grabbing their abdomens and their funduses, because that's going to hurt a whole lot more. Gentle massage and gradually increase that pressure. With cesarean deliveries, again, still that bubble He assessment, incision care, pain, education on how to care for themselves. These women are typically greater risk for clots and other complications because they may be in bed more. Okay, other complications such as infection of the C-section scar. Definitely, we want to be watching for that. In your book, around, I believe, page 232. Let me turn to that while I'm talking about it. Hold on just a second. Apologize. Page 233. There are a list of danger signs you need to be aware of to educate mom about before she goes home. There's also a section on that page that carries over to 234 talking about baby, and so things that you need to teach your mom. So they need to report a fever of 100.4 or 38 degrees Celsius, persistent lochia or lochia that has a foul odor or that returns after a week or two, after pains that are prolonged. And so I'm not going to continue to read this list, but you do need to know it, and you need to know how you would educate mom. Hemorrhage. We talked about early and late hemorrhage. Early hemorrhage can be caused from atony, A-T-O-N-Y. If you think of the word and break it down with your medical terminology, A meaning without, tone, muscle tone, so without tone, so that uterus has a really hard time contracting and keeping mom from bleeding. So that's one reason for early postpartum hemorrhage. Hematoma, which is a collection of blood underneath the skin, or a laceration, and this laceration could be on the perineum, but it could also be on the inside the vagina. It could be even on the cervix, which you couldn't see. But the way you're going to know it's a laceration is when you're massaging the uterus. It's going to be nice and firm, probably at appropriate height, at the umbilicus. No clots, but you see this bright red trickle of blood. But everything else is, the bladder is empty. But then you have this bright red trickle of blood. Kind of pretty indicative of a laceration higher up than where you can see possibly. Okay, we've already talked some about prolactin and oxytocin. The prolactin is the milk production, and oxytocin is the milk letdown. The way I tell students to remember prolactin is pro, meaning, pro. If you can remember that, then the letdown is the oxytocin. You need to know that you need to review the information about breastfeeding. The first few days is the colostrum, then it changes to transitional milk, which is around 7 to 10 days after birth. Mature milk is after 14 days. With the colostrum, this is rich in antibodies, and vitamin A, E, and other minerals. So it is excellent for fighting infection, not necessarily weight loss, but fighting infection in the newborn, or helps them fight infection. Then after the mature milk comes in, then you have the foremilk and the hindmilk. The foremilk is the first milk that starts coming out when the baby starts sucking. It's much more watery. And that's why you want babies to nurse for 5 to 10 minutes or longer to get past that foremilk. You want them to get to the hind milk because that is a higher fat content and it satisfies their hunger. So they need to at least feed on either side 10 to 15 minutes, and that allows for the adequate amount of that nutritious milk coming through. So go back and review in your chapter the influences that are related to the choice of breastfeeding or bottle feeding. You may need to identify some of your nursing measures to help mom in positioning when they're breastfeeding and helping latch on. Also, the education on how to prepare bottles and formula properly. Know the differences between the concentrate, the ready to feed, and the mix or the powder. They're all mixed differently or not mixed, so you need to know the differences and how you would educate mom. Okay. Remember, there's with breastfeeding moms, they need to take in at least another 500 calories per day. They need to have a well balance of proteins, fruits and vegetables, whole grains, and 8 to 10 glasses of water a day. Postoperatively, discharge teaching needs to include follow-up appointments, hygiene, pericare, intercourse. Intercourse can be resumed either after all the bleeding stops or after the laceration or episiotomy is healed, or when mom says it can. Okay, but it can't. It does. They do not have to wait 6 weeks. That's not a hard, fast rule. Diet and exercise, again, depending on if they had a vaginal delivery or a C-section. Maybe some pelvic rock, Kegel exercises, or pelvic tilt, some abdominal tightening. And these are listed in your chapter as well. Your danger signs, again, review those. So in chapter 10, I've already lectured on chapter 10. I want you to go back and again review early and late hemorrhage, what the causes are, and when they occur. Early, obviously, before 24 hours postpartum. Late is after and up to 6 weeks. Early is uterine atony, hematoma, laceration. You need to know the distinction between bleeding from the uterus that does not contract and bleeding from a laceration. Late hemorrhage, retained placenta fragments, and subinvolution. So remember, involution is that time period of 6 weeks postpartum when the uterus is going back to normal size and everything's getting back to some kind of normalcy. Okay, subinvolution is when it is not occurring. All right, you need to also go back in your chapter in your slides and review shock, the 4 different kinds of shock, what can cause it, and how what the signs and symptoms are. And we discussed that, and we also discussed that, I believe, on a slide. Let me see if I can find that one. Yeah, signs and symptoms. Tachycardia. Remember, moms are typically slower heartbeat or Brady, okay? A falling systolic. They're feeling cold and clammy and they're looking pale. Mental status changes and, of course, decreased urine output. And that's not an early sign. That's going to be, where the hypovolemia is not being corrected. Review thromboembolic disorders. Venous stasis is one of the causes of maybe the woman being up in the stirrups or sitting with her legs crossed or being in bed for any length of time can cause that. We have an increase in fibrinogen levels and a decrease in clotting factors. So therefore, mom is clotting more. Superficially, you can have superficial clots, deep vein clots, and they can also result into a pulmonary embolus where the clot's dislodging. Okay. All right. Review nursing measures that reduce a woman's risk for developing postpartum complications. So like phlebitis. What is one thing you're going to have them do? Get up and walk and ambulate, right? Bleeding or infection. Keep that bladder emptied. Drinking plenty of fluids. Make sure you're doing that bubble assessment. With mastitis, remember they can nurse as long as there's not an abscess, but even with an abscess they can pump and discard. If they just have mastitis, they can nurse or pump, and this actually helps the mastitis. So again, review nursing care for all of that. All right. Give me a minute and I'm going to switch over to chapter 12, and we're going to I'm going to record a little bit of chapter 12 today. So we talked early on about the importance of prenatal care, and I keep stressing that, and I know y'all probably say, please stop beating that dead horse, but I can't stress it enough, how important it is. But, you know, even though I'm a firm believer of good prenatal care, we also know that it does not always correlate in the prevention of problems with the baby. But hopefully it will, in many cases, identify those concerns early on so that we can take care of mom and take care of baby appropriately when we need to. Now that the baby is born, it is called a neonate, okay? The baby is called this during the period of the first month of life. Just like mom and dad are going through different physical and psychological adjustments in their lives in recovering from the pregnancy and the delivery and now caring for a newborn, so is the baby. How they may adjust to the outside world is dependent on a lot of factors, and I have those listed here. So we just, I don't know if I mentioned it in previous modules about the mortality and morbidity rates. Mortality rate is defined as those babies who die in the first month. Infant mortality are those babies, mortality are those babies that die within the first month, and morbidity are those babies that die within the first year. The most common reasons these occur are congenital anomalies. I think sometimes we think, we have a healthy baby because mom did everything right and baby looks healthy. We need to remember that adjusting to this world puts a lot of stress on them. And so that first 24 hours is sometimes the most crucial and definitely critical. So adjustment is dependent on a lot. Genetics, how healthy were they, how healthy was that uterine environment, how was the delivery, how did it go. From the moment of birth, a major shift in what is going on with the different organs and systems start occurring. We don't ever need to slap babies on their feet. We do need to dry them off and rub them and stimulate them, but no slapping or hitting. They're coming out in this cold world, and sometimes just that alone will wake them up and get them going, okay? So they're stimulated, those respirations can be stimulated by the chilling effect of just the room and the different chemical changes that are occurring in the body. There are further adjustments besides just respiratory and cardio. GI, neuro, kidneys. Everything is learning to adapt in a very quick moment. After respiratory kicks in, the cardiac system starts functioning and becomes interdependent with the other systems that are changing. So what you need to understand, this is all happening instantaneous, okay? It's not just one thing and then another in a moment or two and then another system in a few minutes later. It's all happening simultaneously or instantaneously, okay? Once that baby takes that first breath. And even though each system is changing and playing a role in the baby adapting, many of these organs still are not mature, okay, from the very first minute of life. They have to mature and adjust in time, but they are functioning. We've already talked in Chapter 6 about Phase 1 and then Chapter 9 in Phase 2, or Phase 2 in Chapter 9. We're going to be moving on over to Phase 3 here shortly, okay, and talking about physical characteristics and the different systems. Your book describes the Phase 3 is between 2 and 8 hours of life. It's a period of abrupt changes in color and in muscle tone. They can become more responsive to external stimuli and noises, but it is also during this period that the baby should start stabilizing. So the nervous system, we have reflexes, okay? They're moving their arms and legs vigorously, but they can't control them. They just kind of go everywhere, don't they? Full-term infants are born with the following reflexes: blinking, sneezing, gagging, sucking, grasping, all of these, and they are part of their survival. Of course, crying and swallowing. They might be able to kind of lift their head a little bit, just a little bit, when they're lying on their little bellies. Other reflexes, Moro. This is where if you hit their crib or you take their hands and you hold them up slightly and you let go of their hands, they're going to kind of bring their knees up, and they're going to flex their arms, and their hands are going to be kind of spread out almost like a C shape. Okay? Rooting, when you stroke the side of their cheek, they're going to turn towards that side because they're looking for something to eat. The tonic neck. This is a postural reflex where they stretch out one arm and flex the leg on the same side. And then they'll extend the arm and extend the leg on the other side. They'll turn their head to the side where the arm is extended. This is sometimes referred to as a sword reflex, and this usually disappears around the 7th month. And then dancing or prancing. When the baby is held up under its arms and the feet are touching the hard surface, they will look like they're dancing or prancing. Okay. On page, let's see. Yeah, 282, 283 are some of the pictures of the reflexes and the different neurosigns specific to infancy, and you need to know those. The head. The head, we know, is the largest part of the largest part of the body in comparison to the other parts. Normal head circumference is anywhere from 32 to 36 centimeters. We need to measure this because we want to watch growth of the head. Also, to measure, another reason we're measuring is to monitor for increase in intracranial pressure. So 12.5 to 14.1 inches or 32 to 36 centimeters. We measure the fontanelles. Remember, the open soft spots also aid in allowing the suture lines to mold during the descent of the fetus. and also for further brain growth. Remember the two different kinds, the anterior and posterior. The anterior closes around 12 to 18 months. It's more diamond shape. Posterior closes around the second month. It's more like triangular shape. So initially after birth, depending on how long the baby was in the pelvis or mom has been pushing, there's going to be what we call molding. Okay, and that's perfectly normal. Remember, the suture lines are not fixed so that they can mold and overlap as they are descending through the pelvis. When they're born, part of our assessment, of course, is to evaluate how much swelling there may be by palpating softly over the head, feeling for the soft tissues, evaluating the fontanelles. Okay, we're also evaluating for how much caput or if there's a hematoma. A caput is it's called caput saccadium. It's just the swelling of the soft tissues, and you can see that in this picture. It will subside over the next 24 hours or so, and there's no need for treatment. Okay, just let mom and dad know what it is, and that there's not any reason for any concern. Okay. But then there's also another situation called a Cephalo Hematoma. Okay? And this is basically, again, a collection of blood up underneath the tissue. And it's a fluid-filled pocket. This is much more disturbing for new parents, but it too will resolve over the next couple of weeks, just like any other hematoma will. Okay? But it is important that we get that initial head circumference. Now, you look at this picture and you say, okay, I can tell the Cephalo Hematoma is deeper, okay, than the caput saccadium, but how do I really tell them apart? Well, the difference is the caput, okay, is just swelling, can cross suture lines, where the Cephalo Hematoma does not cross the suture line. And the suture line I'm talking about, or where the parietal and the frontal bones come together, okay, or the occiput and the parietal bones come together. Okay, that's what I'm talking about, suture lines on the scalp, not a suture line from surgery. Okay, just want to make sure you're clear on that. With visual, it's so fun to watch little babies. Once they, kind of calm down, they start looking and kind of trying to figure out their environment, listening to the different sounds and stimuli. What we need to be aware of and protect them is those unnecessary noises. Those of you that have been in NICU, you notice, even though there's bells and whistles on monitors, it's very quiet. People are not running up and down the hall. They're not screaming across the room. They keep things very quiet and subdued. Tears are typically absent until 1 to 3 months of age. We don't need to overstimulate these kids with TV and radio and video games, of whether they're NICU babies or just full-term healthy babies. Okay. And it is our place as a nurse to educate families about that overstimulation. Ears are well developed but very small. Hearing, they do have the ability to hear at birth. Unless they're sick or they're premature, they may not necessarily respond to sounds. The normal drainage and all that is typically present. We want to assess the placement of the ears. The top of the ear, or the pinna, should be even with the outer canthus of the eye. I believe there's a picture. Yeah, on page 286 is a great picture. Kind of shows you the ear on the left side on page 286 at the bottom. The top of the ear, the pinna, is even or slightly above the eye, and the picture on the right, it's lower, and that would not be normal. Okay? They'll respond to voices by decreasing maybe their motor activity. They may start sucking. They may turn their head towards the sound. And before discharge, we always do a hearing screen to get a baseline to determine if there's any significant hearing loss at birth. We want to teach parents not to stick anything in their ears, no Q-tips, just to only clean the outer part of their ear with a soft cloth. Initially with the newborn, they will go through different phases of sleep-awake cycle while they're adjusting. They typically do sleep 15 to 20 hours a day. Phases of the sleep-wake cycle, they are first reactive, then they sleep, then they have kind of a second reactive phase, and then they become more stable. That first reactive is usually about that first 30 minutes. They're looking around. This is great for helping with bonding and breastfeeding, a good time to start that feeding, okay? Then they start getting a little sleepy. They're less responsive, and they may sleep for a very long time. May even be in a really deep sleep. And during their second reactive, this is after they have slept for a while. And again, they're more responsive and they're more alert. And then after about 24 hours, it's that sleep-wake cycle or sleep-reactive cycle, or sleep-wake cycle becomes more stable and more of a routine. The different sleep patterns you need to be aware of are on this slide, and also on page 287. You need to review those and understand them. Pain. Now, we may think babies don't really feel pain, but they do, okay? And we need to be very cognizant of that. There's several different types of pain assessment tools used on infants and children. These are also on page 287 and 288. Remember, pain in anybody, not just adults, but babies too, produces catecholamines and cortisol. The heart and respiratory rates will change, and even their blood pressure will increase, as does blood glucose levels if they are in pain. Untreated pain, of course, can lead to long-term effects. Those pain pathways and structures required for long-term memory are well developed by 24 weeks gestation. So if we allow a baby to hurt for a long period of time, they will become accustomed to that. I mean, they will remember that, and they will associate certain activities and certain events with pain. And unrelieved pain, of course, can be exhausting and for everyone, but especially that baby. All right. So review those pain scales that are listed in your book, and be aware of those. And this is just this one here I have posted is FLACC, F-L-A-C-C, and this is typically used for infants. And if you look at it long enough, you learn what it is, but you can identify it. It's kind of like an Apgar scoring, but for pain. NIPS, I believe your book describes this one for also for neonatal. It's similar to the CRIES profile. NPAS is for a tool used for babies on ventilators, and PIP is used for premature infants. So we need to be sensitive to procedures, providing pain management, providing comfort measures. I know some of you, when you have seen the circumcisions done, what do they use to help babies besides a little bit of local? They use some oral sucrose on their pacifier, and it's amazing what that will do to help calm those babies down. And it's a safe way of medicating them and helping them through that painful procedure. As the infant becomes older, things they recognize that they may associate with pain can happen. It's a response reflex that is learned over time. So an example I have on this slide is a hungry infant stops crying when it hears its mother's voice, even though food is not available. Okay, they may stop getting hungry over time. All right. The Neonatal Behavioral Assessment Scale, this actually measures inherent neurological capacities. It was developed by T.B. Brazelton, and it was developed to help us identify areas of deficits in the newborn. So they look at alertness, how they respond to visual and auditory stimuli, motor coordination, how how easily excitable they are, and then how they process and respond to stress. All right, so let's start going through some of the systems. Probably won't go through them all right now. I'll probably finish them up on Thursday. So you've already learned that prior to clamping and cutting the umbilical cord, it is the umbilical cord that is the mechanism to provide nutrients and oxygen, right, to the fetus. So remember, it is one vein, right, that's carrying the blood and oxygen and nutrients to the baby, and it's the two arteries that is taking the waste products away. Once it is clamped, the lungs have to take over, supplying the neonate with oxygen and the mechanism to remove CO2, right? Okay. So as a nurse, it is our job to help with suctioning, keeping the airway clear of mucus. What we want to hear with from the baby is a strong, lusty cry that helps inflate those lungs, helps move those secretions out of the alveoli, so that air exchange can occur. And that first hour is the most critical. Just think about all the other physiological changes that are occurring. A lot. So our role. Respiratory status, maintain that airway, suction is needed, monitoring vital signs including respirations. Remember about the Apgar score, okay? We did that at 1 minute and 5 minutes. Sometimes we continue to have to, we may do a 10-minute score just to make sure, okay? And it's always good to look back. What was that Apgar score? It doesn't really tell us. It's not an intelligence test. It doesn't tell us if the child's going to be intelligent or not, but it will at least give us an idea how that baby initially responded to its outside world. So bulb suctioning, you first squeeze the bulb and then put it in the inside gently into the nair, and then allow it to inflate again. Okay. And then same thing in the mouth. We don't go straight down the middle of the throat. We go to the side of the mouth. And again, squeeze the bulb outside of the mouth, put it into the inside on the side, and allow the bulb to inflate, and it will suck out those secretions. And then we push it out on the blanket or a towel, and then do it again if necessary. We've already talked about Apgar score again, but here this slide goes through it again, and you do need to go back and review it and understand it. Even though we're in that third phase, doesn't mean that heart rate can't start slowing down, that respiratory rate can't start slowing down, their color can start turning blue again. And again, we need to be monitoring respiratory status and rate, characteristic, color, and general behavior, and watching for sternal retractions and grunting. Just like the respiratory system, once that umbilical cord is clamped, the baby's circulatory system has to start taking over. There's approximately 300 milliliters of circulating blood volume in a newborn compared to the adult, which has 4 to 5,000 milliliters. You may remember as a fetus, most of the blood bypasses the lungs through what? Okay, let's talk a little bit about fetal circulation. I told you we were going to see this again. The foramen ovale, it shunts blood from the right atrium to the left, and the ductus arteriosus shunts blood from the pulmonary artery to the aorta. Okay? So what else you need to remember is that these close also at birth or soon after. And if they fail, then what? Okay? And so you need to be aware of what your assessment will be, not just respiratory, but circulatory. What are some things you're going to look for? I've said several times respiratory and thermoregulation are two number one things that we're going to be providing for this baby, okay, or monitoring for this baby right from the start. They have an unstable heat regulatory system, so we need to provide warmth. Drying them off. We want to dry them off because with all that moisture on them, it's going to start evaporating, okay? We're going to wrap them. We're going to put them under a warmer. We're going to keep them away from doors and air vents where they can actually lose their heat. Acrocyanosis is evident, and that is where their hands and feet may be bluish. It's typically sluggish because of the slower or sluggish peripheral circulation. So we don't really get too concerned about that, but we do want to take note of it. Okay. Sweat glands do not function, so babies will not shiver. So there's no way for them to elevate their temperature by shivering like you and I would. Okay. We also want to be mindful of the radiant warmer, not to have it too hot. Also, to not overdress them, okay? Here are your normal heart rate and respiratory rate and temperature. We don't want anything over 99.8, and we don't want it under 97.1. And honestly, 97.1 is too cold. Okay, but I believe that is what your book refers to. And it does. But so you go by your hospital protocols. Okay, but for this test, this is what we go by. I have on this slide, you can take temperatures rectally or axillary, and yes, you can, but again, we go by hospital policy, and wherever you would work, you would want to take it according to that, or what is ordered. We want to count both apical pulse for 1 full minute, and we want to count respirations for 1 full minute. So don't place a bed near a window because they might lose their heat through radiation. Okay. Want to keep them covered. You want to only expose small areas when diapering. You want to keep the head covered. You want to prevent drafts to avoid convection. Okay. They don't have a lot of sub-Q fat, okay, to conserve body heat, so we have to conserve it for them. We don't want to place them on cold surfaces. We want the surface to be warm before we put them on that, because if we don't, we're going to cause conduction. And then we want to prevent evaporation by drying them off very quickly. Skeletal is very flexible, are very soft, and mostly made of cartilage. This allows them, of course, to make way through that birth canal during delivery. Muscle development occurs from head to foot and from center to periphery. So that is why they can hold their heads up before they sit. This is important. This is important because if this did not happen, they would not be able to sit up if their head was still lagging behind. So there used to be a picture in your book. Of course, there's not going to be this time. see what. Okay. So again, musculoskeletal or muscle development occurs from head to foot, not from the center of the body to periphery. Okay, and that is why. Excuse me. It is important. They need to be able to hold their head up before they stand. Okay. When examining a newborn for maturity level at birth, one of the parts of the exam is to determine if they have a scarf sign. This is actually pulling the arm across the chest. Elbow should not go past the chin. Let's see, there used to be a picture about that, but I guess not anymore. Let's see. No, there's not a picture in the book anymore. So if you imagine pulling your arm across your chest, you think about it, your elbow typically will not go past the midpoint, okay? Or past the midpoint or past the chin. A full-term infant will actually resist, but with a preterm, it will cross that midline, okay? And that's just one of the gestational tests they look at when they're determining how full-term or how preterm a baby is. They may also appear to be cross-eyed because of the lack of control of eye muscles. Eye color is typically gray or bluish in color up to around 6 to 12 months, and then they usually start developing their permanent eye color. And I've already mentioned that tears don't usually appear till 1 to 3 months because of the immaturity of their lacrimal ducts. Average length is 19 to 21.5 inches, or 46 to 56 centimeters, and average weight is 6 to 9 pounds. Typically, in the first 3 to 4 days after birth, the infant will lose up to 5 to 10% of its birth weight, and this is a result of the withdrawal from maternal hormones, fluid shifts, and loss of feces and urine. And that's a really good reason why we have our newborns follow up in a day or two after discharge so that we can closely monitor this. So I'm going to stop here because I will be covering on Thursday how we calculate this. You will have to know how to do that for this next test. It's not hard, okay? I'll teach you how, but we'll do that then. So, we're going to start on around slide 25. Be sure to listen to this so you'll be prepared to be able to participate in our discussion and review. I will finish up this chapter and then do a little bit more review before our test next week. Have a great evening.